It goes beyond the relationship to an individual. It really embraces a much larger community. And I think these moral voices and ethical actions have to address the problems of economic disparities and disparities in treatment. And they also have to address problems of unethical scientific behavior, where we see fraudulent activities in clinical trials. So this is sort of the dark side, where there is certainly a challenge. And finally, the question, do different systems make different doctors? There was a suggestion that there perhaps are different types of doctors being created by different systems. I would also argue that there is a common core. There's a universal dimension in the culture of medicine which shapes the way physicians practice around the world that is recognizable, as well as local modes of practice and relationships and so on. Let me just give a couple of quick cases here. We have a bit of water. On the end-of-life care, and as part of the conference there was also a workshop with pediatric oncologists in Bangkok. These young Thai pediatric oncologists were delighted with the new kinds of treatments that they were able to offer in parents of children who were suffering from acute leukemia. And yet they themselves felt torn by the problem of how they should relate to the children. How much should they tell the children? What kind of hope could they give children about their possibility of cure for the future? There was a certain kind of confusion and also dismay being expressed in this very interesting workshop, in which people were incredibly open about their own concerns when they were using treatments that they didn't know what the outcome would be. Using experimental treatments for the most severe cancers that they were trying to deal with. And I think that we need to attend to those when we're engaging in medical education, that encountering life-threatening illnesses is part of the action, of course, of clinicians, and how clinicians come to think about that in the 21st century is one of the things I think we need to pay more attention to. One of my colleagues, Susan Block, is interested in the emotional reactions that physicians have towards patient death. And she felt that dealing with dying patients would make physicians really upset. We found in studies that we're doing both in Indonesia as well as in the United States that what makes physicians most emotionally distressed is not the fact that their patient necessarily dies, but if the patient dies a good death. There is a satisfaction, even though one feels sadness. But if patients die a death that is caused by error, caused by crisis in communications, caused by perhaps a fault of the clinician themselves, that's where the emotional distress comes from. And attending to those issues, again, are very important, I think, in the way we come to understand how physicians experience the affective and emotional part of their work. In the mid-20th century, sociologists used to refer to physicians as having detached concern or affective neutrality. But we don't really find that. We find a lot of affect over the kind of work and pediatric oncology, what was happening in pediatric oncology at the time that we began the study. There was a workshop on the future. There is a future for children with cancer, and the person who opened the workshop was a young lawyer, 27-year-old lawyer, who told about her own treatment and the experiences that she had. One of the things that was really incredibly powerful about this. It was a workshop in which new data was being presented on a clinical trial and the effectiveness of the clinical trial. But she was the actual first person before these clinical trials were introduced to become cured of ALL in Jakarta. She reflecting on her experience, she speaks about, my childhood was filled with suffering, and she went on at great length actually about how the treatment was very arduous. After radiation, at that time a naughty boy pulled my hair and my wig came off. I was shocked, I was so ashamed, I could not cry. My tears had dried up. She had been crying over the course of these treatments. Why did I have no hair? What did I do wrong? My questions swept through me, through my inner being. Whatever happens to me, however, is the reality. Those days passed quickly. My hair grew back. I graduated from primary, then middle school. The blood tests every 2 months, 5 full years. By 1982, I was the first person in Jakarta to be cured, free of leukemia in the blood. Now I am truly healed. I praise God who are giver of all. So this workshop opened with this, and then we moved on to actually look at the data that was coming out of the clinical trials. Clinical trials was a twin trial. These trials were being done all around the world on the effectiveness of particular anti-cancer therapies. And the Jakarta group were working very closely with a Dutch oncologist who was head of the International Pediatric Oncology Association. And it was a very difficult set of presentations because even though there was improvement in treatment and in care, the attention to the kind of science was questionable. So when one looked at the data being presented, it looked like 40% of the people in the children in the clinical trial of JOJA were proceeding to remission and potential cure, whereas 72% in Holland and 84% in the US under the same anti-cancer therapy were proceeding to cure. And that led people in Jakarta to ask the question, what is going on here? And it really is quite a concern. One of the things that happened was that they found where the children were being treated, the windows in the hospital were made out of wood, rather than, the window frames were made out of wood rather than metal. And wood produces fungus in tropical settings. And so the children were coming down with secondary infections. And the secondary infections required antibiotics. The political economy of hope worked here. The Cancer Association was paying for the anti-cancer drugs, but not for the antibiotics. If the parents couldn't afford the antibiotics, they'd completely pull the kids out of the treatment. So it turned out that really only about 25% of the kids were actually being brought to a state of apparent cure. The spin-off, however, from having this clinical trial over the 10 years that it went on proved to be very effective because the improvement in the local setting where the treatment was going on was extraordinary. They changed all the windows, they changed the way the science was being done, and they introduced an entirely new way of carrying out the experiments and the clinical trials, and also providing drugs. So this particular situation led to a far more technically sweet treatment process than had occurred earlier. The truth-telling to parents has also been very interestingly worked out, where the Dutch mode of being frank and straightforward has been integrated into common practice, and telling the truth, quote unquote, in certain ways is common. So this is just for your amusement. The and time. Harso is one of the artists who we work with, and this is his Indonesian and Rhode Island self, Republic of Indonesia, Rhode Island, where he also lives, stayed in the United States, near us in Boston. And he carries the confusions that sometimes people feel when they're working with difficulties in the modernist era. I'm going to go very quickly over this end-of-life study because I don't want to take much more time from Byron's presentation on mental health. But one of the projects that my Indonesian colleagues and I also have been carrying out at Sarjito Hospital is to look at the experience that physicians have with patients dying and with managing end-of-life care. No matter what we do in the medical imaginary, we certainly have to confront death. And looking at the way clinicians respond, the way physicians respond, it brings us into the inner life of medicine in a particular way. The study was first carried out amongst internists in the United States at academic medical centers in Boston, and then the Indonesian group at Gajah Mada University wanted to carry it out there. They wanted to know what was going on with their own clinicians, and also to improve end-of-life care within the teaching hospital. So these are the names of our staff and our faculty. Dr. Yati Sinar, who is head of pediatrics, and our pediatric oncologists and psychiatrists. The method we used was fairly straightforward. We had both open and closed questions, replicating the American survey, and we were asking physicians how they experienced caring for a patient who died recently, that they had been taken care of, and also the most emotionally powerful death, and we asked them to reflect on that. The group was quite similar in terms of gender breakdown. One of the things we found that was different was that Indonesian physicians were far more likely to be present at their patient's death. They didn't abandon their patients. It wasn't the nurse or the family that were sitting by the side, as usually was the case with Americans. But they were there, and especially they were there for the most emotionally powerful death. In most cases, Indonesian and American physicians have similar, these are academic physicians and academic physicians in training, have similar attitudes about the end of life and about dealing with death. The rankings for emotionally powerful, disturbing, and satisfying are all the same, but what is different is how physicians in Indonesia regard patient suffering. They felt that their patients were suffering far more than did the American physicians. They themselves also wished they had more support and the American physicians than their American physician counterparts did. We began to ask questions. What's going on? What's the difference between the American and university and Indonesian group? Again, with the most emotionally powerful death, we actually, find the statistically significant difference between the Indonesians and the Americans on patient suffering. Again, they felt their patients suffered more. They felt they needed more care. They felt it was